Welcome back, everyone, to OpenLine. We are talking with Amanda Brancht and Michael Randolph, both with the Mental Health Cooperative, about a program, Partners in Care, in which clinicians go with police officers on calls. And it's happening in two precincts right now, the North Precinct, the Hermitage Precinct. We're going to talk about why those precincts in a moment. I want to get to a call. Let's go to Vicki. Hello, Vicki.
Hello. How you doing?
Go right ahead.
I wanted to say this. During my son's situation, I was trying to talk to the chief about mental illness. Okay, and I had a list of stuff, and that was the first one on my list about what was taking place. He didn't want to listen to what I say, so I fought the chief about this situation. What's going on?
Now, are you Vicki Hambrick?
Yes, I am.
Tell us about your situation again.
Andrew Delkey shot my son in 2018. So I wanted to sit down, and have a conversation with the chief about some of the stuff what was going on here in Nashville. And that was one of on my list. What I wanted to talk about is mental illness with people out here.
Did you feel like your son?
Some people.
Did you feel like that was a problem for your son?
No, it wasn't no problem with my son. It was some more with other people that I know about.
Okay.
And I was trying to, get them help.
Right. So
and I was talking to some mothers and fathers out here, and they was like they didn't want that happen to what happened to my son happen to their kid. So that's why I wanted to sit down and talk to the chief about that.
But you're saying that didn't happen in your case?
No, because my son didn't have no mental illness.
Okay. All right, Vicki, thank you. Thank you for calling.
Thank you.
Yeah. Okay. So that's interesting. Thank you again, Vicki, for calling in. Clearly now police are very interested in this issue. Would that be a fair statement? Either of you can take that. What would you say, Amanda?
Yes, I mean, definitely. I've said this before, and we have worked for years to try to get a crisis intervention team in Nashville. And, I've been doing this work for 20 plus years. And 10, 15 years ago, we kept running into roadblocks. And I think it was because there wasn't the collective buy-in from all the entities that needed to be involved. And I would say in the last year and a half, 2 years, the police department definitely became very motivated to look at how they could do this differently. I think they were likely getting feedback from frontline officers. They were also looking at data and seeing the amount of time that officers were spending on mental health related calls. And they were getting that direct feedback from frontline officers. At the same time, we as mental health are saying, look, we know that this is a problem. We're seeing it when we do get the calls from the officers. They're needing more resources. And then we had the health department coming into play and saying, look, we want to bring the stakeholders together, try to pull all of the data that the various systems have to improve. And as soon as we did all that, we got everybody in the room, all the key players in the room, it actually started moving very fast. And I do think that there were people who were in key positions within the police department to help move it along from that perspective. The creation of the alternative policing unit, and Inspector Imhoff and Lieutenant Brooks have been great to work with and really champions of this. And I think that's what it really took. It took buy-in from the leadership within the police department, from the chief on down, to really champion this amongst the entire department. At the same time, we as mental health had to take a critical look at how we were doing our current crisis delivery system and saying, how could we do better? And one of the things we needed to do better is to look at how we were inadvertently creating barriers for officers to access the services when they identified somebody who had a mental illness. So it really took all of us coming together. And
how were you inadvertently creating barriers? What do you mean by that? How did it used to work? It used to work, officers would show up on the scene and maybe they would call for crisis intervention. Is that right? Or I guess, how did it work and how were there barriers?
Yeah, so officer would be on the scene. They may identify that there needs to be a mental health issue, and then they call our crisis line. And we'd go through this triage process of gathering a lot of information. Well, sometimes in gathering all of that information, the officer's still trying to manage the scene while he's on the phone with us, gathering demographic information and history and all that. Whereas we needed to say, look, the officer's there, he's identified, she or he has identified an issue. We can get all that information once we're on the scene. Let's not delay it. Let's move it on. Because the longer we delay care, the more likelihood that situation is going to become more stressful for everybody involved and could become a situation where the individual in crisis is escalating to the point where that officer is going to have to intervene in a way that none of us want them to have to intervene. So we had to say, wait a minute, our system is delaying this, and we've got to improve in that way.
Interesting. You want to say something? Yeah.
Yeah, I would say we built a crisis treatment center a few years ago that really is the hub of what makes this program work and kind of revolutionize police drop-offs here. So before we were able to build the crisis treatment center, a police officer would have to stay with an individual in crisis until they were assessed and treatment was found. This could take hours, and if they needed a medical clearance, it could take days. With the average time an officer was having to spend with a person in crisis before we had the crisis treatment center was over 140 minutes. With the new building, they were able to cut down police drop-offs to around 8 minutes.
That's great. Okay, let's go to another call. Let's go to Mary Helen. Hello, Mary Helen.
Yes.
Go right ahead.
Well, I've got a few questions. I'm just going to throw this out there. I'm a first-time caller. How do y'all know if somebody doesn't have, like, low blood sugar, dehydrated, or something like that when you approach a scene and it may appear to be manic? Because when your sugar goes low, usually your adrenaline kicks up, to keep you from passing out and stuff. Now, how do you know that's not a situation? And likewise, in these days and times, they're different than when I came up in my father's generation. I saw people that were World War II vets that when they came up on a mental health situation, there were cops. They'd seen enough of that in World War II to know what it was, and they didn't tackle or beat somebody. I've seen them for myself talk people in emotionally distressed situations, talk them down. So it's nothing new that this has been done, but it seemed like we've neglected this. And the other thing is, how do you know if the person who called the police doesn't have a mental illness like schizophrenia or paranoid schizophrenia, that they're freaking out, calling on a friend of them that they think is against them or something, and they call for a welfare check? And how do you know that if somebody that lives probably in the neighborhood that has a little clique in it of a bunch of emotionally immature 50 and 60-year-olds don't like the person that moved in, that doesn't want to join in their swingers clubs or their pot smoking groups or whatever it may be? So how do you totally assess a situation to really know that it is a mental illness, or people are using the cops against somebody else as their own personal weapon? Thank you for listening.
Mary Helen, great to hear from Mary Helen here. All right, what about that? Go ahead.
That's a great question, and I think that really illustrates the importance of really thorough, expansive clinical assessment. So if a counselor goes on scene, they're getting a lot of collateral information. This could include calling whoever called the police and say, hey, what made you call the police on this person today? And kind of having a conversation with that person. This could be calling the support system of the person that we're here to see. Generally, when it comes to ruling out a medical problem, we will ask the individual in crisis, what kind of medical problems do you have? If they're diabetic, that could be like a ting of like, okay, this could be a blood sugar issue. If they're denying any medical problems and we talk to their family and their family says they have been diagnosed with bipolar disorder, or the individual says it, we're able to say that this could more likely be bipolar disorder. And, with that, having that officer there, they can key up on the radio and get an ambulance if it is a medical emergency. But really, the more thorough you get with your collateral information and talking to the person in crisis, is able to give you a clear clinical picture of what's going on.
Very good. Thank you. Thanks for that call, Mary Helen. We'll take a break, come back, continue our discussion right after this.